Okay. Um, Considering there is only three of us right now, so myself plus three of you guys, we'll try and make this quite interactive. Um, oh, we might have one more actually. Excellent. Okay. Even so, because it's such a small meeting, it'll actually probably work a lot better if you guys are more engaged and like can chat back and forth with me. I'll be able to give you all a lot more individual attention, which is good. So if people could just, when I ask questions, unmute themselves and try and talk rather than put it in chat, that would be ideal, because otherwise it's going to feel a little bit strange, me just ignoring only 7 of you guys here. So with that said, we'll get started. My PowerPoint run. There we go. Okay, so this is Acute Delirium with me, John O'Neill. If you've not had any teaching with me before, I am a intercalating medical student who's just finished his intercalation in critical care. It's a BSc in critical care from Plymouth. And I'll be going back into 5th year soon, 1st of September. Hopefully, same as all of you guys, if coronavirus is still going on, we'll take it and just smash placement and have as much fun as we can in Liverpool as usual. This is going to focus mainly on delirium, acute confusion, with some references to dementia and how to differentiate the two. We're going to go through all of the theory of delirium first, and then at the end, we've got a small case discussion to go through, which is going to be where the majority of the interaction comes from. And I'm going to hopefully get you guys to be a little bit responsive, ask you questions on what management and investigations you're going to want to do. So with all of that said, we'll get started. So today we're just going to go through, first off, what is delirium, its definition and how you can recognize it, risk factors for it and causes for it, and then the diagnostic tools that you can use to recognize it and quickly classify the severity in the A&E or environment or on the wards and ITU. Then we're finally going to cover the management, both non-pharmacological and pharmacological, and finish with a case discussion, which, as I said, I'm hoping I can get as many of you involved in as possible. Right, so start off with, what is delirium? So delirium, also known as acute confusional state, is a common clinical syndrome characterized by what you would imagine is disturbed consciousness, disturbed cognitive function, altered perception, which have to be acute in onset and fluctuate over the development of its course. So by acute, it will come on in 1 to 2 days typically, and fluctuate. So some days they'll be better than others. Some days they'll be hyperactive and aggressive. Other days patients will be really reserved and compliant or spaced out, and it's very changeable. Despite this, delirium is a very serious and often overlooked condition, just attributed to pre-existing cognitive deficit or other conditions such as depression. But it does have a significant impact on outcomes and length of hospital admission. So it's very important to recognize quickly, and obviously it predominantly affects elderly patients that already have quite a reduced physiological reserve. So that said, delirium itself is divided into 3 separate subtypes, all of which are distinct from cognitive disorders such as dementia and depression. And delirium, if diagnosed early, is totally reversible with non-pharmacological management, as well as identification of underlying cause. So, dementia, on the other hand, just to really get in our heads the differences between the two, is a chronic progressive neurodegenerative disorder which is characterized by global non-reversible impairment of cerebral function. So this is what you guys are all familiar with, classic long-term cerebral cognitive decline. It's characterized by all the same things as delirium, but over a much longer period of time. And it has a very slow deteriorating course over the course of years, typically up to 10, whereas delirium, as I said, is typically 1 to 2 days. They'll go from completely normal to like totally confused, not knowing where they are. Dementia also has extended periods of stability where the cognitive function will be the same. So it won't be perfect, but on that declined point, it will be stable for maybe months or years at a time. Whereas delirium will jump up and down across the spectrum of totally confused to essentially normal over the course of maybe even 1 day. Most importantly, though, just because a patient has dementia doesn't mean they can't also have delirium on top of that. And in fact, pre-existing dementia in an elderly patient is one of the biggest risks for developing delirium, because they already have such a reduced physiological reserve in their cognitive function. Confusion will show itself far more quickly in these patients than they would, say, your standard 30-year-olds that you would pull off the street and suggest some kind of physiological stress. So why is it important? Well, these are some figures that I stole straight from Life in the Fast Lane, which is a really good website for revision. If you guys need any more resources for your exams, I would highly recommend using Life in the Fast Lane. So in adult patients on ICU, it's up to 80% of ICU patients will develop some degree of delirium if not monitored closely. And it increases mortality up to 3.2%, well, sorry, 3.2 times at a 6-month period. It prolongs both your ICU stay and your hospital, and can, if not dealt with early, lead to measurable and permanent cognitive defects 12 months. If you don't correct this, it can lead to permanent cognitive decline. So going back to those 3 different subtypes, got hyperactive delirium, hypoactive delirium, and mixed, which is what the majority of cases will present as. So those mixed deliriums are the classic. They'll flip between both, maybe over the course of a whole day. Hyperactive is your classic running around the A&E department, trying to fight off staff, get out of bed, resisting treatment, that kind of thing, which is a lot of the time the most stereotypical depiction of delirium, but in fact it's only about 1% of cases present this way. It's also the easiest one to diagnose and is very rarely missed. So these patients actually tend to get much better treatment and management than the opposite end of the spectrum, the hypoactive delirium. So these patients often are missed because they're typically very, very compliant. They'll sit there and agree with everything that you say, be fully, happy with any sort of treatment that's going on, but aren't quite with it. A lot of the time they might not speak at all to you. They'll be fully withdrawn, and these kind of patients are more closely associated with other psychiatric conditions such as depression or psychosis, because a lot of the time they become so scared, or they're hallucinating to the point where they sort of retreat within themselves and deliberately don't want to draw any attention to themselves. So these are the sort of patients you need to be careful for. They might appear normal, chatting away, and the next day they just won't respond to any sort of stimulus they put. Most patients, however, will present in a mixed form. So this is a bit of a busy slide, but basically all of the major risk factors are what you would sort of expect. So things such as your age and pre-existing dementia as I said, are your two biggest risk factors for acute delirium, because it reduces your physiological reserve. And so any stress that your body is then put under is going to have an impact on your cognitive function, whereas it wouldn't necessarily do so in patients that didn't already have that stress on them. So other things such as histories of hypertension, physical frailty, alcoholism, high severity of illness, all increase that physiological pressure placed on the patient. And particularly if something like age is coexisting, as it typically will, that'll be enough to push patients into confusion and delirium. The causes for dementia and delirium are, sorry, the causes of delirium are extensive. Almost anything that causes an acute illness also cause delirium. But there is a useful acronym which is just called SMAShed, which I find quite helpful to remember a few of the causes, because often particularly hyperactive delirium patients can be mistaken for being drunk, for example, in the A&E department. So I think SMAShed is quite a good way to remember this, because it lets you quickly run through all of the different possible causes for that behavior before you revert to the fact that, oh, they're just drunk. We'll go over that shortly. I've got a whole slide dedicated to it. But first, I just want to mention the next point, that obviously patients usually, because of these risk factors, don't just present with delirium. Most delirium patients will have another condition that's causing their delirium and could be masked by that confusion. This is important because delirious patients are obviously very poor historians. So someone comes into the A&E department acutely confused, that's the first thing you notice. And if you ask them any further questions, you're not going to get information on what might be causing that confusion. So it's very important to look at other avenues. So check out your hospital records, see if there's anything else that you can find on that patient, their details. If they come in with any family members or carers, there's a very good resource for collateral histories. You phone the patient's GP to get accurate medication, and medical histories are very important. Collateral history should be your number one investigation for patients with acute confusion. Okay, so next up, obviously this is a cognitive impairment, so you might want to image their brain. After all, head injuries do typically lead to confusion. But CT and MRI can be useful in acute onset, particularly if there's a history of head injury. But many of these patients, because they're elderly, will present to you with sort of incidental findings, like minor changes in their ventricles and cerebral spinal fluid makeup, which could potentially attribute it, but isn't a definite cause, and it could end up leading to overdiagnosis and investigation. So it's actually best to reserve CT and MRI scans for those patients that come in with a clear indication, such as a head injury that you can visibly see, or history consistent with findings of raised intracranial pressure. So anything like headache worse on lying down or leaning forwards, vomiting, waking up during the day, or findings on fundoscopy towards increased cranial pressure. Any signs of focal neurology as well should indicate a CT scan. The delirium could be the result of a stroke, and some findings such as aphasia, which could initially just be a sign of confusion, might be hiding a more sinister cause such as stroke. So this is where I want to throw my first question out to you guys. Is there any other differentials that you think would indicate the need for a CT? What could you be looking for, and what patient would you think that when they come into the A&E department, these guys need a CT? So feel free to either unmute yourselves or just put something in the chat. Yeah, thunderclap headache, perfect. So something like a subarachnoid hemorrhage could definitely present with confusion. intermittent like fluctuations in consciousness levels and things like that, in addition to the thunderclap headache, would definitely indicate a CT. Anything else? Traumatic head injury? Yeah, definitely. I for sure want to stick a patient through a CT scan if they came in bleeding everywhere from a head injury. There's one I'm particularly thinking of in patients that might have a long-standing diagnosis of dementia, cognitive impairment, elderly patient presenting with maybe Parkinson type symptoms of apraxia. No ideas? Okay, no worries. What the next slide is for. So, everybody familiar with normal pressure hydrocephalus? So this is quite an interesting condition, which is often missed, and patients are just labeled as having dementia, because it has a fairly similar progression to dementia. So rather than being days of onset, such as in delirium, or years of onset, like in dementia, it sort of has an in-between phase. So over the course of maybe 1 or 2 years or a few months, 8-month period, its etiology is not completely understood. It's theorized to be potentially an issue of CSF reabsorption, predominantly affecting elderly patients. You can see on the CT scan, we have this greatly increased size of the ventricles. This attributes to this actually maintains, so there's with this increase in the ventricles, the internal pressure inside the cranial cavity doesn't really change. So on lumbar puncture, you'll get a normal pressure, hence the name normal pressure hydrocephalus. But with that said, you still get degradation and compression of the gray matter, leading to this cognitive impairment. And the long-term time frame is what often gets it confused with dementia. These patients are really important to try and spot because this is reversible. And sometimes patients will be labeled with a diagnosis of dementia for several years before someone recognizes a pattern of this. And this is actually completely treatable with surgery, reversed. And these patients get vastly improved quality of life afterwards. So the classic triad of symptoms you guys might be familiar with for this is cognitive impairment, apraxia, and urinary symptoms. So this is it: wacky, wobbly, and wet, the three. Wacky for dementia, wobbly for gait apraxia, wet for urinary incontinence, as well as other urinary symptoms like urgency. So in these patients, obviously CT and MRI are going to be very important because you're able to identify those increased size of the ventricles and in that case rule out diagnoses of a dementia. However, can't diagnose this purely on imaging alone. So you need to put that into context of your other investigations. So for example, as I said, you need to do a lumbar puncture that will show up as normal. If you get increased pressure on the lumbar puncture, it excludes this as a diagnosis and should funnel you more down the avenue of a space-occupying lesion. And you also need to do something called a levodopa challenge. These patients can also be mistaken for Parkinson's disease or variants of dementia like Lewy body dementia. So if you do a levodopa challenge in these patients, you give them a trial of levodopa over a few weeks period and see if their gait apraxia improves. If it improves, then you can attribute this down to Parkinson's or Lewy body type dementia. If it does not, then you know this is down to normal pressure hydrocephalus. Once you've confirmed the diagnosis, as I said, treatment is pretty much curative and is essentially a surgical shunt, ventricular peritoneal shunt, which will drain the excessive fluid and allow the brain to decompress. They're not suitable for surgery. You guys need repeated drainage and cardiovascular risk management, just to keep any of their blood pressure control as low as possible, because hypertension will exacerbate this problem. Okay, so now we've covered all of the head injury stuff. This is smashed. So this is all of the things that can potentially cause delirium in a patient. This is quite useful because consultants and short answer questions in your paper sometimes will ask you about possible causes of delirium. And you can't really get it too badly wrong. But this is just a useful way to categorize it in your head, because otherwise I know sometimes if someone asks you a question and there's a bunch of answers, it can be quite hard to formulate something that makes sense when you're trying to respond. So if you start off at the beginning and go through, this is quite a good way to do it. So substrates, beginning, / sepsis. Sepsis is obvious, but substrates is anything such as hypo or hyperglycemia, HHS, and DKA type pictures can all cause delirium, as well as thiamine deficiencies. Think of conditions such as Wernicke's and Korsakoff's. Mental illness and meningitis, psychosis, and CNS infections are covered under all of that. So any of your conditions like schizophrenia or mania, and then infections of the CNS, again, such as meningitis, encephalitis. Alcohol, obviously, in itself, so smashed should immediately point you towards alcohol, but the A inside it is also alcohol, both intoxication and withdrawal. So things such as delirium tremors and Wernicke's. Seizures, and then the H is hyper / hypo. So basically any changes in homeostasis, be that hyper or hypothermia, hyper / hypothyroid, and then electrolytes and encephalopathy. Finally, drugs. So almost any drugs could cause delirium in the right dosages. Particularly, you want to look out for anticholinergics, is the big one. So elderly patients on anticholinergics. So those are typically anything that people are placed on for bladder control. Big one that's often seen is oxybutynin, which frequently causes delirium and falls in elderly patients. If possible, you should always avoid prescribing anticholinergics to any patients with the risk factors that we looked at on the previous slide. The other one that's fairly obvious is things like hallucinogenic. So benzodiazepines and antipsychotic agents, pain management, and ketamine. Polypharmacy as well, so interactions between trauma and urinary and fecal constipation, also major risk factors for this because they lead to infections and confusion in patients. Not mentioned in this algorithm, so it's worth just giving a special place to remember purpose. This I thought was quite a good little slide to quickly summarize all of the different drugs and cause the usual delirium. This isn't all-encompassing, and on the previous slide, as I said, I mentioned that digoxin, which itself has subtle anticholinergic properties and known to be associated with delirium. But these are a pretty good catch-all. So for patients on any of those and presents delirious, unless it's essential for their management, it should be stopped as soon as possible. Big ones I would definitely mention is, as I said, the oxybutynin, the incontinence agents, and sedating antihistamines is chlorphenamine and diphenhydramine. Right. So, how do we properly diagnose delirium? There are a number of different diagnostic tools that are available in hospital, but I'm going to cover 3 today, which we'll see most commonly. This is the main one most people will come across, and this is CAM, or the Confusion Assessment Method. This is really good, and there is a version for it in patients that are unable to speak or that are intubated at the same time. So that's the CAM ICU, which I cover both in there. And the main overriding thing between all of these assessments I'm going to cover is that they test for inattention, disordered thinking, and altered consciousness. And you need at least 2 of those in order to be diagnosed with delirium. So all of them. So here on the CAM, you can see that initially you just want to identify that they have a fluctuating or altered mental state. Then you want a long form task. So in this case, they use the months of the year backwards. So it needs something that's repetitive but long form in order to test for inattention. Then feature 3 here is just looking at the Richmond Agitation Sedation Scale. So this is just to check that your patient isn't already sedated. So if they are, then you can't take any further progression in the test. You just ultimately diagnose them with delirium because they're sedated. At that point, you should try and reduce their sedation to the point that their Richmond score is 0 and they're fully conscious, and then redo the test. If they have a normal Richmond agitation score, then you progress and assess disordered thinking. Essentially, to any non-delirious patient is just a series of quite silly questions, but anyone with delirium, obviously mix up any of the answers. And you only need 1 error in any of the disordered thinking in order to confirm a diagnosis of delirium. The alternative to this is the CAM ICU, which rather than having them say the months of the year backwards to test inattention, just has them squeeze your hand after you say a series of letters on every time that you say the letter A. So it's the same principle, long form task that tests their ability to maintain their attention for an extended period of time. But again, in order to do this, you need them to have a RAS score of 0. If they don't, automatically score as delirious, and you need to reduce their sedation in order to redo the test. Other scores that you see are things such as this. This is the 4AT, which is essentially what most of you will do when you're just classically assessing a patient on the ward for confusion. So just want to see if they're initially what their alertness is, then check their personal details and see if they can accurately name themselves, where they are, and what the time of day/year is. And then inattention again. So you want a long form task, either the months of the year backwards or the method used in the CAM ICU, getting them to squeeze your hand over a series of letters. Finally, we have the abbreviated mental test. It asks 10 questions, and a score of 8 out of 10 or less indicates delirium. I personally find this very useful. It allows you to track a patient's cognitive status over over the course of their admission. So for example, if they come in and you initially score them with the abbreviated mental test, and they get a 6, then as they progress over the next couple of days of your management, score them again and they get an 8, you know they're improving. Even though they're still delirious, they're not as delirious as they were. It's obviously not going to be these are just the 10 questions you ask, but again, you'll notice that it's testing the same sort of thing. So particularly inattention, with the attempts for them to recall the address that you give at the beginning and the count backwards from 20. All of these work very well, but the AMT, though it has good ability to track the patient's progress, it's quite culturally specific. So things such as the dates of the First World War and who the Queen is isn't going to be a fair question to ask a immigrant that's English as their first language. So they're going to score unfairly on this test. So it's not great for anybody that's not a native English or British person, or who hasn't had a full secondary level education. So in those patients, CAM and CAM ACU definitely preferred, because they don't take into account any sort of cultural references and are available for everybody got education level. So for that reason, these are the main ones used by NICE and recommended by most hospitals. Are asked to do delirium screening patients. CAM is probably your best bet. Although if you want, AMT is good as well if they're a native British person, and you want to track their progress over the course of their admission. So we've got our patients, we've done our screening tool on them, we've identified a couple of risk factors that they've got. Now we want to try and manage their condition. So the initial management is obviously deal with any underlying cause. They come in with raging sepsis and that's making them confused, the sepsis. Fairly self-explanatory. Likewise, anything if they come in with retention, constipation, giving them a catheter or laxative will make them improve very rapidly. However, patients post these interventions can still remain confused for a considerable length of time. And so the best thing you can do for these is to ensure that you have effective communication and reorientate the patient as frequently as possible. Because a lot of the time, due to their acute delirious state when they are admitted to hospital, they have no memory of any of the events that have taken place from when they have to where you are now treating them and their management. So trying to recap them on the events and reintroduce yourself every time you meet these patients does a lot to ground them in the moment and help them move forward. If they're not kept in the loop and communicated with effectively, they sort of never get the ability to recenter themselves in their current position and then progress. Other things that can really disrupt this schedule. So care environment, side rooms are probably best for these patients, because being on the main wards in the bays is really going to mess with their sleep schedule. They're going to get abnormal lighting for the time of day, which then messes with their circadian rhythms, leads them down an ever more confusing path, which exacerbates their delirium. Finally, important things like inclusion of family members in the care, if available. Visits from family members are very important in order to help provide friendly faces and reground this patient. And one thing that I personally found very important dealing with patients like this on the ITU is making sure you provide them with any sort of visual or auditory aids that they usually have outside a hospital. So, for example, we had a patient on the units for a while who had really bad spinal injury, and a sepsis over the top of that. While he was very confused, we couldn't communicate with him effectively at all, and we assumed that he was delirious, and so we're just acting in his best interest as much as possible. His family then came to visit, and after some discussions with them, we realized that he actually usually required quite strong prescription glasses in order to, like, read and understand the world. So after we were able to provide him with his appropriate prescription, we started using a language board that he was able to spell out his desires on. And moving on from there, we were able to get on top of his confusion and get into a much more like patient-centered care where he could get much more involved in what we were doing. Obviously, we never would have found that out if we hadn't realized that he actually just needed glasses. That's an important moment. Yeah, so this is just what I was saying before about making sure you create an appropriate care environment with lighting at the right time of day. Obviously, if you put all the lights on in the middle of the night, your patient isn't going to go to sleep. If they don't sleep, that's going to add to their confusion and further mess up their circadian. Other things that will confuse them, ward-to-ward transfers. So they'll get used to all of the staff on the wards and start recognizing people, which is a really good way for them to start feeling like they're becoming less confused. Move them to another ward, whole different environment. You've changed where the location of the toilet is, as well as all of the basic staff, and that's going to make things a lot worse. Obviously, you can only go so far with a lot of these management, and for your hyperactive patients that are fighting you and refusing care, it's important that you're able to get on top of that and treat them in the most appropriate way. So though additional medication should always be avoided if possible, after all, a lot of these patients have become acutely confused because of polypharmacy medications that are direct risk to themselves, other patients on the ward, or you're unable to treat them properly and they're refusing your treatment though they don't have capacity to do so, then antipsychotic therapy and sedatives can be used to calm these patients down. First line management for all of these patients is haloperidol. It's a first generation antipsychotic. If anyone's unfamiliar with it, it is good at stopping hallucinations. So many of these patients will be very distressed because they are hallucinating. And it also has sedative properties. So if you give it at night, for example, it will aid with their sleep cycle, help them sleep through a little bit longer, and make them more compliant when trying to treat them. It's important that you start on the lowest possible dose and titrate up to the point where it's effective. Always keep your dose as small as possible. You want to wean them from this as soon as you have their delirium under control and their main illness dealt with. Some patients can't give haloperidol to, because obviously it's a first generation antipsychotic, which notoriously have quite bad Parkinsonian or extrapyramidal side effects. So anybody that has pre-existing Parkinson's type symptoms or Lewy body dementia, is potentially likely, as dementia is a major risk factor for these delirious patients. You can't give haloperidol. Absolutely contraindicated. It's going to these guys work. So those patients, sticking to the same principle, we want something that's relatively sedative. It's going to help them sleep and calm them down. So for that, these guys we use lorazepam. Lorazepam is also first line for anybody experiencing delirium due to alcohol withdrawal. So should we use the same way? Lowest possible starting dose, titrated to the level where it's effective, weaned as soon as possible. So that is effectively all of the theory that we're going to go through for now, before we move on to our case discussion. So just to summarize, the most important part of managing delirium is recognizing that it's present in the first place, in those hypoactive patients, because they won't be jumping out of bed, they won't be wandering around the wards, and they won't be fighting you off. So it's very easy to just do the treatment that you think is most necessary and wander off without trying to focus on resolving their confusion. And these are the type of patients that miss the long-term deficits down the line. Always check in patients that have dementia if their confusion has changed recently. So collateral histories are essential for these patients. They have carers or family members present. How long have they been confused for? Has it changed recently? Are they more confused or less confused than usual? Delirium itself is multifactorial, and detailed investigations of all of the potential factors should be taken in any patient suspected of dementia. And management ultimately should ensure the treatment of the underlying cause and adapt the care environments to minimize any confusion for the patient, with any pharmacological sedatives reserved as a last resort. Okay, before we move on to our case, any questions for me there at all? No? Okay. Good stuff. So here's our case. Violet, excellent old lady name. Violet is an 82-year-old lady who normally lives alone and is helped out by her son, who lives in the area and visits regularly just to do her shopping and cleaning. Earlier today, her son returned from a shopping trip and found Violet on the floor, short of breath and with pleuritic chest pain. So after calling 999, they both arrived in your A&E department. The ambulance crew noticed that Violet seemed confused over the course of their journey. They've been unable to get any more detailed history of the events prior to her son's return. How do you want to start? Come on, guys. Let's go a lot faster. A to E. Yes, of course. So we always start with A to E, particularly if we don't know what's going on with this lady. That's Violet, just to give you a little bit of empathy for the situation. So yeah, as always, A to E. So I can tell you that Violet's airway is patent and she's maintaining it well, talking to you. Her breathing is not too bad, but you're a little bit concerned with a respiratory rate of 22. The chest expansions are equal bilaterally, but shallow, and her SATs are 92%, with some crackles heard on her left base. Her heart rate is 98. Blood pressure is 110/85, and a CAP refill is just over 2 seconds. Her pulse is regular and good volume. Pupils are equal and reactive to light. Blood glucose is 8 and her GCS is 14. She's fully responsive to you, but her speech is very confused, not stringing together. You find no focal neurology. Her temp is just slightly pyrexial at 37.6, and you notice a tremor present in her upper extremities. What do you want to do to start off with? Bloods in a chest x-ray, seems reasonable. Oxygen, yes, good. So number one, her SATs are 92% and she's got a raised rest rate. So slapping some oxygen on her is probably going to be your first port. Raise that before she deteriorates. You never know, her hypoxia could be the cause of her confusion. So putting oxygen on straight away, if she improves, you know that's all it's down to. So moving on, what investigations do you want to consider? So yeah, bloods and a chest x-ray, really good shout. So admission bloods, we're going to do all of those things. Is there any other investigations that you guys think could be relevant here? She's got acute onset confusion and a few worrying signs. How do you want to narrow that idea of what's going on? Blood glucose. Yeah, we've already done that in her A to E, came back as 8, which is maybe slightly elevated, but nothing to worry about. AMT, yeah, not a bad call. Start off early and categorize her level of confusion now, and then we're able to follow that up later as we do interventions to improve her condition and see if that improves her AMT score at all. So good shout there, Monica. What about a few more investigations to better define her presenting complaint? So she's come in with shortness of breath and chest pain. What investigations do we want to do to rule out some of the worst possible causes for those? ECG, yes, perfect. So this could be an atypical presentation of an MI. Always watch for that, particularly in elderly ladies, often don't present with the classic crossing chest pain. So anybody presenting with shortness of breath, chest pain, even pleuritic in nature, should get an ECG. With that said, considering her chest pain is pleuritic, is there anything else people might want to do? Well score, yes, cool. She might be having a PE, D-dimer, yeah, okay. Good stuff, guys. So other thing, ABG could be useful in this patient. If she's having a PE, ABG is going to show up a bit of a respiratory alkalosis and a VQ mismatch. So this is quite a valuable test. And it doesn't necessarily need to be an arterial blood gas. Stick this on at the end of your admission bloods as a venous blood gas, and it'll give you almost as much useful information. So this is always worth taking in patients that present with shortness of breath, because it will also give you a lactate, which is very useful, particularly patients querying sepsis or anything that you might be worried about in DKA. D-dimer, as was said, very good call. This is potentially a very classical PE presentation. And blood cultures. So we had a great call about chest x-ray, querying the cap, potentially after hearing crackles on her chest. Before you start antibiotics, you're going to want to take blood cultures. This way, later down the line, you'll be able to tailor your antibiotics specifically to anything you grow from your blood culture. Chest x-ray, obviously. And finally, would anybody CT scan this lady at this point out of interest? I'll take that as a no. I could be, yeah, so that's fair, not yet. She was found on the floor, which indicates a fall. so she could have fallen and injured her head. However, on your inspection, you've not found any focal neurology and there's no obvious head injury. So I wouldn't say it's necessary. Could fall, so it's worth keeping in the back of your head as a possible investigation. If you don't find anything else on your other investigations, that gives you an explanation for her confusion. Okay, so you send off your appropriate investigations and you start your chosen management of empirical antibiotics for your query of a chest infection and oxygen to deal with her hypoxia, which is now correcting the type 1 respiratory failure that you found on the gas that you sent. Because you were very judicious one and you sent all of the right investigations. So you'll be pleased to know that Violet is now doing very well. Her respiratory rate has settled down again and her SATs have come up to 96% on the oxygen. Unfortunately, on further questioning, it's clear that Violet is still confused. She thinks that she's arrived in a hotel and keeps asking you to go and get her some Eggs Benedict. So you're unable to get any more useful information about her past medical history directly. So it's clear that her confusion isn't simply due to her hypoxia, because you've now corrected that. So what other options are open to you to get information about Violet's past medical history? Yes, well done. So he came to the A&E department with her in the ambulance. So he should be your immediate port of call, right next to you, worrying about his mum. So he'd be an excellent resource to get further information. However, what other options are open to you if your son, for example, if not your son, her son, for example, has no idea about her medication history? Contact the GP. So if the son is there, even if he doesn't know about her medication history, he will know her GP's contact details if you don't have them on the system already. So even if you can't get the information directly from him, you'll be able to get other sources of information from the details he already knows. The same is true for carers. If anyone comes in from a care home with a carer with them, even if they don't have all of the information, they will have contact details of other parties that will have the information. Okay, so you question Violet's son and you discover that she was actually recently diagnosed with Parkinson's disease and has had a diagnosis of mild dementia for the last couple of years. However, despite this, she normally manages well and is usually orientated in time, place, and person. You decide you need to screen for delirium. What tools are available to use quickly in the emergency department? So we've already had the mental test, the AMT mentioned. What else can we use? Yeah, exactly. So CAM or CAM ICU are going to be your number one go-to here, just as an initial rapid assessment to just say, yes, they have delirium or no, they don't have delirium. CAM, as I said before, is universal and doesn't rely on culture or educational background in order to get an accurate diagnosis. So it's really useful, just a few questions and we'll just works. Bonus points, what are the main things that you're testing for in a CAM, as you are in most other delirium screening tools. Disordered thinking is one. Yeah, perfect. Inattention. Yes, well done. So those are the two big ones. The other third is just fluctuating mental state or cognitive decline, which is present if you pick up the two others. So, good work, guys. You were clearly paying attention earlier. So you use CAM score and you confirm a diagnosis of delirium superimposed on her dementia. This is just a refresher on how you do the CAM. So chest x-ray you ordered during your initial investigation confirms a diagnosis of community-acquired pneumonia, and you switch your antibiotics from empirical to your hospital guidance for community-acquired pneumonia after appropriately curve scoring. A few days into her management, Violet is doing well and no longer requiring oxygen support, and you have resolved her fever thanks to the antibiotics. However, ward nurses are having trouble during the night. Violet keeps attempting to get out of bed and wander around the ward. Having already had a minor fall the previous night, the ward sister asks if you can prescribe anything to help Violet sleep through the night. What would you like to give her? Lorazepam, yes. Well done, Monica. So in this case, haloperidol is normally first line, as I mentioned, but you have a history of Parkinson's disease that you've picked. So in this case, you would jump straight to lorazepam in order to help stabilize his sleep pattern and prevent her from causing further damage to herself. Okay. The lorazepam started on a very low dose and has improved Violet's sleeping pattern. Seems to have helped her somewhat. Her son, however, is visiting regularly and is still concerned that she seems more confused than usual. Following the fall reported by the nurses, you decide to ask her son if she's had any other falls recently. And he confirms that she's been unsteady on her feet for a while, having tripped and fallen quite hard in the garden, but hasn't bothered to go to the hospital to check her out because she seems fine, and Violet didn't want the fuss. Now your consultant suggests a CT scan might be appropriate. Any theories on what the CT scan might show in Violet? Elderly lady, recurrent falls. Subdural. Yes, so that would be number one differential in this kind of patient. Very easy, these to arise with no obvious external damage, just from shearing of the veins. And so your CT scan comes back with this picture. Is a chronic subdural hematoma. So if this was done immediately after the event, can see this dark area would highlight bright white with the increased luminosity of the blood. However, over time, as that forms a clot, it darkens and starts to match the color of the brain a lot more closely. So small ones of these can be missed. And so always check these scans, really search around the outside for anything that just looks slightly off. In this case, you can see quite a clear one with midline shift, made clear by compression of this right ventricle. Any idea what the procedure is if you were to find this in a patient? Well, hopefully, Violet is stable enough for neurosurgery to clear out her hematoma and restore her brain function. The neurology department has a look at the scans and confirms chronic extradural hematoma and accepts Violet for further management and assessment. So well done. You have successfully managed Violet as best as you possibly can and passed her on to neurology, who's going to decide whether or not she's appropriate for any surgical management of her hematoma. But otherwise, she's doing well and has improved markedly under your guidance. And with that, concludes our little chat on acute confusion and delirium. It's a bit of a whistle-stop tour, but the key points are just to remember to carefully assess your patient for any underlying causes and be sure not to allow dementia to cause diagnostic overshadowing of any acute confusional changes which might have happened on top. Because correction of these can substantially improve patients' qualities of life for a long time afterwards and improve their more immediate outcomes with, as I showed you before, mortality drastically increased in patients that don't have their delirium managed. So thank you all for coming. I'm just going to quickly post a survey in the chat. If you don't mind filling out some feedback for me, I would really appreciate it. Let me just get the link up. Sorry, you guys having to see my Facebook feed. Hope it was useful, and please feel free now to ask any questions. You can unmute yourself and just chat a little bit if you want. Otherwise, post it in the chat, and I'll address it as best I can. My pleasure, guys.